these rashes on exposure to the sun. These rashes were present for about a week or 10 days, and they disappeared spontaneously without any treatment. This was the photograph of the rash that he was able to provide to me. In February 2022, there was swelling of both the feet, which was gradually progressive. And over a span of 10 to 15 days, he noticed that there was periorbital puffiness, and he was not able to wear his own shoes. He also complained of froth in urine at this time. All these above symptoms of easy fatigability, rash, and onset of swelling, they were not associated with any history of decreased urine output, blood in urine, passage of stones in urine, burning micturition, flank pain, hesitancy, poor stream of urine. There was no history of any chills, rigor, evening rise of temperature, any night sweats, any loss of weight, loss of appetite, or any palpable lump in the body. There was no history of any bleeding from any site in the body. There was no history of chest pain, shortness of breath, cough, sputum production, or sore throat. There was no history of any jaundice, altered sensorium, black-colored stools, abdominal pain, vomiting, or loose stools. There was no history of any cold or heat intolerance. There was no history of any drug intake or any alternative medicine intake. There was no history of any joint pains, oral ulcers, headache, nasal crusting, eye complaints, or weakness in any limb at this point of time. Then he visited his local doctor, and he was found to have high blood pressure of 50 to 150 by 100 millimeter of mercury. He was advised some blood and urine tests, and after the review of reports, he was advised to visit a nephrologist because he was told that he is leaking blood and protein in his urine. And his serum creatinine was also 2.1 milligram per deciliter, which he recalls to be normal as per his previous medical checkups. He was started on tablet Ramipril at that time. Then he visited a nephrologist and was informed of a positive ANA report and possibility of an autoimmune disease or a vasculitis. After an ultrasound, he was advised a kidney biopsy, which he refused at that time. He recalls being started on tablet Omnacotil 20 milligram once daily and tablet Diador. After 2 weeks of follow-up, that is in March 2022, his blood and he came back with his blood and urine reports, and his creatinine was 0.8 milligram per deciliter. His steroids were increased to 40 milligram and tablet cotrimoxazole was added. His antihypertensives were optimized. Then in follow-up in April 2022, he improved symptomatically with minimal swelling and no fatigue or fever. He remembers that his steroids were tapered and they were stopped over a period of 1 month. After 2 to 3 weeks of stopping the steroids, he developed multiple joint pains. These joint pains were present in small joints of the hands. They were symmetrical. They were associated with morning stiffness of more than 30 minutes. And within 2 to 3 days, he noticed that these joint pains are also present in his both the feet joints. It was not associated with any swelling or tenderness around the joints, but it was associated with easy fatigability that was restricting his daily activities. So in May 2022, he again noticed the swelling of his feet, which was again gradual onset and progressive and associated with periorbital puffiness. But this time he noticed decrease in his urine output, which was both in frequency and volume. It was associated with decrease in his appetite. These symptoms, however, were not associated with any blood in the urine, any dysuria, urgency, hesitancy, any fever or abdominal pain. There was no history of shortness of breath, chest pain, palpitations, blood in sputum, or alternate medicine use. No history of any sore throat, eye discharge, eye pain, urethral discharge, numbness, or tingling sensation of any limbs. He revisited his nephrologist and was found to have high blood pressure on his current antihypertensives. His serum creatinine level has now increased to 2.9 milligram per deciliter, and his urine again showed leaking of blood and protein. On 4th of June, he underwent an uneventful kidney biopsy, and he was told to have a severe form of lupus, and he received 3 doses of IV steroids. Since his elder brother was working in a pharmaceutical company, he was aware of some trials that were going on for lupus, and he requested his nephrologist to enroll him in one of these, and hence was referred to us. After reviewing and on further inquiry to us, when he came to us, he also complained of difficulty in swallowing since 1 week, which was present for both solids and liquids, and it was associated with pain in the throat along with retrosternal burning sensation. He underwent an upper GI endoscopy and biopsy at that time, and he was told to have some viral infection and was started on treatment for it. He underwent again a certain urine and blood investigations, and this time he was told that his proteinuria is of 4 to 4.6 grams per day, and his repeat serum creatinine was 1.5 milligram, which after a week returned to 0.8 milligram per deciliter. He was started on oral steroids and mycophenolate methylphenidate. Hydroxychloroquine and aspirin were added. Calcium and vitamin D supplementation was done. He's currently regular follow-up with us, and currently his symptoms have improved with minimal swelling, no fatigue, joint pains, or fever. Past history, he complains of alopecia for around 10 years now. He received treatment 10 years ago, but had no benefit, so he left the treatment. He also complained of bluish discoloration of digits on exposure to cold 5 years back, which was not associated with any pain. He also complained of oral ulcers 2 to 3 years back, which were painless, and it was present on the palate as well. He took treatment from local doctor, and it subsided with the treatment in 1 to 1.5 months. Personal history, he is a vegetarian by diet. He's a non-smoker, non-alcoholic, has normal sleep, and has no alteration of any bowel bladder habit. Family history, his mother died at the age of 45 years due to intestinal cancer. His father was an army officer. He was diabetic and a history of stroke present. He died in 2020 due to brain abscess. He has 2 elder brothers. The eldest brother is 49-year-old. He's diabetic and hypertensive. And the elder brother is 48 years old and he's hypertensive. The patient himself is unmarried. So shall I summarize now?
Dr. Manish, would you want her to give us
you can summarize. Yeah.
Yes, sir. He is a 46-year-old gentleman with past history of alopecia, oral ulcers, and Raynaud's phenomenon, presented with 5 months history of worsening constitutional symptoms, which were associated with...
Sorry, Kamakshi, to interrupt you. What
Yes,
happened to this Raynaud's? You said 5 years back he had this symptom. So
sir, he did not take any treatment for that. He said that it used to occur for some time, and in during the cold season, in the winter season, and it was mild in nature, so he did not take any treatment for it.
But they continue to happen even now.
No, sir, they are not happening right now. They just happened at that time, and now it is not present. And associated with self-limiting maculopapular skin rash and later anasarca. On evaluation, he was found to be hypertensive with history of active urinary sediment, raised serum creatinine, and a positive ANA. He refused for the kidney biopsy at that time, was started on oral steroids and diuretics, responded well to it with improvement in symptoms and normalization of serum creatinine. Hence, steroids were tapered and stopped after 3 months. After withdrawal of the steroids, he developed bilateral small joint symmetrical polyarthralgia and anasarca with active urine sediment and raised creatinine level. He underwent an uneventful kidney biopsy this time in June 2022 and was found to have severe form of lupus nephritis. He received 3 doses of pulse steroid and came to us for enrollment in the lupus trial. On further evaluation, he was found to have nephrotic range proteinuria. He complained of dysphagia, underwent an upper GI endoscopy, was found to have viral esophagitis, and his immunosuppression were modified accordingly with oral steroids and mycophenolate methylphenidate. He came to us for regular follow-up last week with no fresh complaints.
Okay. Yeah, you can carry on.
Okay. So then I would like to proceed for the differential diagnosis after my history. I would like to keep my syndromic diagnosis to be as nephrotic syndrome, with the possibility of lupus nephritis as my first diagnosis, as he was told to have ANA positive active urinary sediments, and the biopsy was suggestive of lupus nephritis, and he came to us to be enrolled in a lupus trial.
You can just tell your diagnosis. We'll discuss
Yes, sir.
why you are keeping this thing like in detail if required.
Right.
You can just narrate your diagnosis.
Okay, sir. However, I would also like to keep a possibility of ANCA-associated vasculitis, cryoglobulinemia. IgA being the most common glomerular pathology, I would also like to keep IgA vasculitis, though lower down in my differential.
Any other thing in diagnosis?
So this is all.
Yeah, because there was hypertension also. So do you think this
Yes.
hypertension is secondary to renal involvement, or do you think this is essential hypertension?
Sir, because he was undergoing regular medical checkups every 6 monthly in his office, and he wasn't diagnosed to be hypertensive at that time. So I would like to keep it along with acute nephritic syndrome, sir, as a part of nephritic syndrome.
But there was a strong family history, both brothers as well as father, I think mother also. So strong family history that will point towards maybe it is an essential hypertension. So one can debate. So, but that
Yes.
should come in diagnosis at least. That what
Yes,
is your
sir.
thought process about hypertension? Any other thing in diagnosis? So another thing which this patient was having, as per history, was viral esophagitis. Again, that
Yes,
should
sir.
come in your diagnosis. What is your thought process about that viral esophagitis? What do you think? Which virus was that? And what do you think was the treatment? And this would complete your diagnosis.
Yes, sir.
Whatever diagnosis you are presenting is just about centric to kidneys, not looking into the other aspects like hypertension and viral esophagitis and other things.
Yes, sir.
So one should give a complete diagnosis. Even at the end of history, if you are presenting diagnosis, you should give a complete diagnosis, right?
Yes.
So should we discuss now, or we go ahead with investigation and discuss?
Either ways, Dr. Manish, I think if she completes, then probably we can sum it up in one go and then have a detailed discussion, whichever way. Yeah.
So you can go ahead with your investigation.
Yes, sir. So on examination, he was conscious, oriented to time, place, and person. His weight was 64 kgs and height was 1.6 meter and BMI was 23 kg per meter square. He was afebrile at that time. His blood pressure was 120 by 70 millimeter of mercury in right arm sitting position. His pulse was 78 per minute, regular, normovolemic, synchronous. Vessel wall was not thickened. All peripheral pulses were palpable with no radial or radiofemoral delay. He had pallor present. There was no icterus, cyanosis, clubbing, lymphadenopathy. There was mild bilateral pitting pedal edema was present. Here he had scarring alopecia present. He had acne over the back. There was no xanthelismas, no maculopapular rash, no oral ulcers, no nasal crusting, no saddle nose deformity. There was no joint deformities. There were no joint tenderness or swelling or tophi. His fundus was normal and the urine dipstick did not reveal any abnormality. On systemic examination also, there was no positive findings. His chest was clear with normal vesicular breath sounds, and CVS examination was also normal with no murmurs, no pericardial rub. The abdomen was soft with no bruit, no tenderness, and nervous system examination were also normal. Sir, his investigations in February 2022, his HB was 7.5, his TLC count was 6.2, and platelet was 265,000. His ANA was positive at that time, and his urine routine examination was done. With the pH of 5.5, he had 3+ of proteinuria, and RBCs were 20 to 25 per high power field. WBCs were 15 to 20 per high power field, and his urine culture was sterile at that time. His creatinine trend over the period on 1st of February, it was 2.1. When he visited his local doctor and the nephrologist, and after starting of oral steroids without a biopsy, his creatinine came down to 0.8 in 19th of March. Then on a regular monthly follow-up on 3rd of April, his creatinine was 0.8, and after stopping of steroids and following polyarthralgia and again anasaka, his creatinine was 2.9. Here he underwent a biopsy, and he was given pulse steroid for 3 days. And before presenting to us, his creatinine was 1.5. And after 10 days of follow-up with reports, his creatinine was again 0.8 milligram per deciliter. His urine routine in March showed RBCs of 1 to 2, and protein was traced in WBC was 2 to 4. In April, his urine routine was protein was traced in RBC were 2 to 3, and WBCs were 1 to 2 per high power field. On 30th of May, that is before the biopsy, his urine routine showed 3+ protein. RBCs were 20 to 25, and WBCs were 20 to 40. And when he came to us, we got a spot urine protein creatinine ratio done, which was 4.62 grams. Then he underwent a kidney biopsy. This is the kidney biopsy where on light microscopy, there were 15 glomeruli, and out of 15 glomeruli, 20%, that is 3, were globally sclerosed. The glomeruli revealed diffuse mild to moderate increase in the mesangial cellularity and matrix. There was segmental and global endocapillary cell proliferation. There was variable intracapillary and mesangial neutrophil infiltration. 4 glomeruli, that is 26.6%, revealed overlying cellular crescents. 1 glomeruli revealed segmental fibrinoid tuft necrosis, and 4 glomeruli, 26.6, show subendothelial deposits. 1 glomerulus showed secondary segmental tuft sclerosis. In tubules and interstitium, his interstitial fibrosis and tubular atrophy involved 20 to 25% of the sampled cortex. There were variant tubules which show prominent cytoplasmic vacuolar changes and patchy acute injury. There were few hyaline cast and granular cast were seen in the tubular lamina, and there were focal chronic interstitial inflammation was noted. His arteries revealed mild medial thickening, while arterioles show focal hyalinosis lesions. His immunofluorescence included 4 glomeruli, and it was a full house with the IgA 1+ mesangial and deposits were there in mesangial and capillary wall, granular and pattern. IgG were 3+, same mesangial and capillary wall and granular in pattern. IgG1 was 3+, IgG2 was 2+, IgG3 was 1+, IgG4 was 1+, IgM was 1+, C3 was 1+, C1q was 1+, and kappa lambda were 3+. There was patchy granular staining for IgG and C1q and kappa lambda light chains along the tubular basement membrane as well. So the impression of diffuse lupus nephritis, according to the ISN RPS 2018 class 4 was made. And the modified NIH score for disease activity was 15/24, and chronicity score was 3/12. That's also.
So any change in your diagnosis? Can you go to the diagnosis? Do you want to make any change in it after whatever additional information?
So now it is class 4 diffuse proliferative lupus nephritis. Sir.
You want to add anything into the diagnosis other than what we have discussed, like hypertension, viral esophagitis, after your examination? after
Yes.
your investigations?
So then I would like to add systemic lupus erythematosus as my diagnosis. And I would like to give sir, according to the scoring system, I would like to score it and include it with my diagnosis as SLE with lupus nephritis, class 4.
No, that's not what Dr. Manish is asking, Kamakshi. Of course, you rightly pointed out that you would want to keep a possibility of SLE first and then lupus nephritis. That goes without saying. But what he is referring to is that would you want to still consider things like ANCA-associated vasculitis or granulomanemia? So they are practically out after you have seen the biopsy report. So this is what you want. So the final diagnosis which you want to give now, which of course should also include hypertension, whether it is a primary or a secondary.
Sir, I would like to go with lupus nephritis only.
Right. One more thing which was very interesting and very obvious in your investigations was a hemoglobin of 7.5 in February 22. After that, you have not mentioned what was the follow-up hemoglobin. But even if on follow-up, say the hemoglobin has improved, what is your diagnosis about what is your possibility of that 7.5 in a male patient in February?
Yes, sir. In a male patient presenting with anemia, sir, with this presentation, I would like to keep autoimmune hemolytic anemia, since he did not give any history of bleeding from any site or occult bleeding. So I would like to keep autoimmune hemolytic anemia as my possibility.
Any DD?
So second anemia of chronic disease can be one, sir.
No, that was in February, no, that time, like not severe renal dysfunction and nothing was there. So again, anemia should come into your diagnosis to complete your.
Yes.
Now, coming to your main diagnosis and the clinical diagnosis of, you have said nephrotic syndrome. Like, so you have given more importance to nephritic rather than nephrotic. Otherwise, it should have been nephritic syndrome. But why you are thinking this is a nephritic syndrome?
So because the patient presented with the swelling anasaka with presence of hypertension, there was edema, hypertension, and proteinuria and hematuria.
No, these are so edema, hypertension, proturia, proteinuria. These are manifestation of nephrotic syndrome, right? I am asking what are the components. So, what are the components of acute nephrotic syndrome? What is the definition of acute nephrotic syndrome?
Sir, it is the presence of proteinuria, hematuria,
And
glomerulonephritis.
no,
So the definition is not this what you are mentioning. There is a set defined criteria to call as acute nephritic syndrome. That includes cola colored urine, hypertension,
yes,
oliguria, with or without renal dysfunction. Proteinuria is not a, so proteinuria, if it is a significant proteinuria, it will become nephrotic syndrome. It will not be a part of nephritic syndrome. So like in this patient, there was no cola colored urine. There were RBCs in the urine that was on microscopic hematuria. There was no macroscopic hematuria, right? Yes. Oliguria plus minus. Once you have mentioned there was some decrease in urine output, but again, not very impressive. Hypertension, we have already debated whether it is an essential or secondary. Even your nephrotic syndrome can have hypertension. So my point is why you are so much focused on nephritic syndrome, why this can't be a nephrotic syndrome per se, because we are talking about the secondary nephrotic syndrome. We are not talking about a primary nephrotic syndrome in which microscopic hematuria should not be there, classically speaking. We are talking here a case of secondary nephrotic syndrome with lupus nephritis. So RBC can be there as part and parcel of nephrotic syndrome. Yes, so that was my question, like why you are keeping nephritic syndrome?
So Kamakshi, would you want to give some importance to the azotemia, the oliguria, hypertension, yes, hematuria, and azotemia? Would you want to give some importance there?
So the renal dysfunction that happened, the rise in the creatinine that happened, and it improved with the steroids, and
right.
that will
So yes,
go in
so
favor of
rather than
nephrotic.
other things, you should give importance to azotemia. Now, suppose I ask you, okay, azotemia is fine, but why not it is nephrotic syndrome with AKI? Still, I am not sure about nephritic syndrome. Why not it is
Yes.
nephrotic syndrome with AKI? You have treated nephrotic syndrome, everything has improved.
Sir, in nephrotic syndrome with AKI, the reasons can be, sir, any sepsis, any drug intake. So he did not give any history of fever or infection or any drug intake or alternative medicine intake or NSAIDs intake. Then so he
Yeah,
did not
that
give any history of.
these if they are there, they will help you. But you know, nephrotic syndrome per se can cause acute kidney injury because of interstitial edema. You don't
Edema.
have to have any additional injury.
Yes.
So question is how you differentiate nephrotic syndrome with AKI with nephrotonephritic syndrome.
Um, Sir, so renal,
If you have AKI and nephrotic, Kamakshi, what kind of pattern do you have? What kind of deterioration of the renal function do you have? I mean, vis-a-vis nephritic, vis-a-vis rapidly progressive renal failure. What is the rapidity with which an AKI will worsen as compared to a nephritic illness or an RPGN?
So in RPGN, the renal failure will worsen within days, 2 weeks, and there will be oliguria, anuria, and in nephritic, in acute nephritic syndrome, the renal failure will be there, and that will also be, sir, with some rapidity. However, in nephrotic syndrome, that could be the rapidity will be less. It will be more gradual, and
No, Kamakshi, don't get confused. Just listen to Dr. Manish's question. He's basically wanting you to differentiate between AKI and a nephritic syndrome. The rapidity with which they come. What do you believe comes so rapidly and it is so rapidly progressive? The quickest to progress is?
so the crescents.
No. In terms of whether it is AKI or whether it is RPGN, which is quicker, which is faster?
So the AKI will occur very quick.
And if untreated, what happens to it?
Sir, it will lead.
Deterioration will be much faster, you see, it will be much faster as compared to nephritic will give you time, even RPGN will give you more time. So based on your history, if you look, what was the worst creatinine?
So 2.9.
And then what happened and how quickly did it respond?
Then, sir, it came back to within. So after treatment only, it came back to 1.5 and then 0.8, sir. It took about 2 weeks for it to come down.
Okay. So with the kind of information which you have provided and subsequently with the investigations, I think we are straightforward as far as diagnosis is concerned that this is a systemic lupus erythematosus with lupus nephritis. But second diagnosis of ANCA-associated vasculitis. Can you have ANCA-associated vasculitis in this patient, say with ANA positivity, and you were short of biopsy, like biopsy report was not available? Can you still keep ANCA-associated vasculitis?
Yes, sir. In about 10% of the patients with ANCA-associated vasculitis, we can have ANA positivity.
No. This you are confusing again. 10% of ANCA-associated vasculitis can have, or even less than, can have combination of lupus nephritis and ANCA vasculitis. What I was asking was ANA positivity. And you know, ANA positivity will be there in almost 100% of cases if you are doing it with immunofluorescence. So that is why you have to do with ELISA, because
Yes.
ANCA is also kind of, it will give a false ANA kind of thing, right? So if you do just by immunofluorescence, there may be false ANA positivity. So you confirm it with ELISA. So you rule out the false positivity. That was my question. right? So you can,
Yes, sir.
even in NCA positivity or NCA associated vasculitis, you can have a ANA positivity. So
Yes.
you should confirm it further. That was my question. Yeah, other things like IJ vasculitis and pyoglobinemia, I think we can straight away rule them out. But NCA can have combinations. So short of biopsy, you can still debate because this is a male patient and with this age group. So again, coming to male patient, how common is SLE in the male subject?
Sir, in the like in the prepubertal age of less than 15 years of age, the female to male ratio is 3:1, and in like in adolescence, it is 5 female is to 1 male. However, in adult childbearing age group, it is 8 to 15 females is to 1 male. And after 60 years, however, it is a little less. 2 females is to 1 male is the ratio. So.
Yeah. So you are right. So in adult age group, it is predominantly like almost 90% will be females and 10% or maybe less than that will be males. So it is exceedingly rare. I would not say rare, but uncommon to have a male patient with lupus nephritis as compared to a female patient. So that was again one reason where you can still keep ANCA-associated vasculitis short of biopsy. But now we have biopsy, so that sorts our issue. So still, in this case of SLE, what do you think? Which criteria are fulfilled for making a diagnosis of SLE?
So sir, the criteria for SLE, like the latest criteria, which includes ANA as the entry point of at least 1:80 titer on the human epithelial 2 cells. That's the entry criteria which he fulfills, followed by at least 10 points from the clinical and the immunological criteria is required. So in the clinical criteria, he had fever, which gives it 2 points. And then sir, he did not have any neurological manifestation, and he did not have any serositis in the form of pleuritis.
You can just tell the main things like which are
Yes,
fulfilled in ACR.
then he had discoid, he had oral ulcers, he had discoid alopecia, discoid lupus, that is in the form of scarring alopecia, and he had fever, renal involvement. Class 4 lupus itself gives us 10 points for this criteria to be fulfilled. And in immunological, we have ANA as positive criteria, sir.
Right. So he fulfills more than adequate. But are these criteria classification criteria or diagnostic criteria? And what is difference between these two?
So these are the classification criteria, ULR classification criteria of SLE.
So what do you mean by classification criteria and what do you mean by diagnostic criteria?
So for the the classification criteria, they include they are more sensitivity and specificity for these criteria. In ULR criteria, it is like 93% sensitive and 94% specific for this, which involves a wide variety of manifestations of SLE that can happen, and not only the most prevalent ones, sir. So we can
my question is, what is difference between classification criteria, any classification criteria vis-a-vis diagnostic criteria? What do you mean by diagnostic criteria and what do you mean by classification?
We diagnose it with the help of like lab investigations. We diagnose it with the help of immunofluorescence and ELISA test. ELISA being the more confirmatory test. So, sir, and this is how this is the classification criteria, sir.
No, I think you are not getting what I am trying to ask, but anyway, it's okay. So prior to this ACR ULR, which criteria we were using?
Sorry, sir.
Prior to this ACR ULR, which criteria we were using?
So it was SLIC criteria, SLE International Collaborating Clinic.
Right. If we talk about SLIC criteria and ACR ULR criteria, as far as renal involvement is concerned, what is the difference between SLIC and ACR ULR?
Sir, in the SLIC criteria, there was a straightaway criteria for biopsy proven lupus nephritis in the presence of ANA or anti-DS DNA.
Right. And in ACR ULR?
In the ACR ULR, sir, there are renal manifestations and other. The ANA has to be the entry criteria, and then
I am asking about renal, only renal.
The renal
Forget about
criteria,
ANA.
it includes in the ACR ULR criteria, sir, it includes proteinuria of more than 500 milligram in 24 hours, which is given, sir, 4 points, and 8 points are given to 10 points are given to class 3 or class 4 lupus, and class 1 or 2 and 5 they are given 8 points, sir. 2 or 5 they are given 8.
That is what. So what is your interpretation as a nephrologist about renal biopsy criteria of SLIC versus renal biopsy criteria of ACR ULR? What is your interpretation?
So then we see the activity index and the chronicity index.
No, forget about activity index and chronicity index. I am asking, again, listen to me. SLIC criteria, renal biopsy proven lupus nephritis makes a diagnosis of SLE, right? ACR ULR criteria, they have given point system according to class, right? So what is, as a nephrologist, what is your interpretation of this difference? Are you getting what I'm asking?
Yes, sir. With so it also it did not so the SLIC criteria used proteinuria as more than 500.
No, I am again, forget about everything else. Just focus on biopsy. Just focus on biopsy in SLIC versus biopsy in ACR ULR. Forget about everything else.
So the hypercellularity.
No. So in SLIC, what was the criteria? Renal biopsy proven lupus nephritis makes it SLE. But in ACR ULR, what they have done is they have differentiated according to the class of lupus nephritis. So if it is class 3 and 4, it straight away gets 10 points. ANA positive with class 3 and 4, it straight away makes a diagnosis of SLE. But ANA positive with class 5 or class 2 will not make a diagnosis of SLE. Are you getting me? Okay, because that is the importance of ACR ULR for a nephrologist. They have given importance to the class of lupus nephritis, unlike SLIC criteria. SLIC criteria, everything which is lupus nephritis suggestive is SLE. But in this, they have said that class 3 and 4 are more specific. So straight away they get 10 points. And for making a classification diagnosis of SLE, you require 10 points. So any SLE, any patient who is ANA positive with biopsy of class 3 or 4 will straight away become a diagnosis or classification SLE. But if they have a class 5, class 2, you require something else. Maybe it is fever, maybe it is immunological criteria, maybe anything else. But it will not straight away make a diagnosis of SLE. So are you clear on this? So yes, this is the importance difference as a nephrologist. Other things are, of course, are there, like point system, scoring system. And what was another important thing in ACR ULR, which was not there in SLIC or any other criteria? Again, this is more concern for rheumatologists and more concern of people who are into classification criteria, not of much concern to a clinician or a nephrologist, is the presence of fever. They have included presence of fever as a classification criteria, which was not there earlier. So these are the important differences you should know between ACR ULR and the SLIC criteria, right? So if we even take ACR ULR,
Kamakshi, of course, you did mention about fever, and that automatically gave 2 points to your patient. And what's important, what the point which Dr. Manish is wanting to bring home is the difference between the main difference between the two classifications, what you were referring to, but were not thoroughly clear. 0.5 grams is what we were having earlier on. Now, the newer ACR ULR criteria, 500 milligrams will give your patient only 4 points. And of course 4 for proteinuria of more than 0.5, 8 for class 2 or class 5, and 10 for, if it is class 10 and ANA, it's okay, the diagnosis is made. Even if it is 2 and 5 and you have ANA, something else which gives you maybe from the skin or the anemia or something, it gives you point. But the mere proteinuria will give your patient only 4 points, and you now have to have at least 6 more to be able to label, and that's where you will struggle. Let's say your patient has just class 1. It's very rare to have class 1. Then even that patient or class 6 patient can have some degree of proteinuria, and you will not be able to label this thing. And then coming to Dr. Manish's first question, very important. You see, the diagnostic criteria and classification are two different things. Now, based on this classification criteria, you can enroll your patients in various trials, but even if you have made a diagnosis of a given disease based on the diagnostic criteria, you will not be able to include that patient in under any role unless you are able to classify that patient according to the classification. So they're two entirely different entities. You can base your treatment according to the diagnostic criteria, but you cannot move forward in any research protocol unless you have the classification criteria. So that's the importance, and that's why we are improvising and changing every year and year, a few years, right?
Yeah.
Yes.
Now,
so again, to reiterate, like to make a diagnosis of SLE, you don't require to fulfill ACR Euler criteria. So I would give an example now. With the inclusion of mandatory criteria of ANA positivity, people start thinking that there is nothing like ANA negative, or if the ANA is negative, we should not diagnose them as SLE. But that is not correct. That is for classification, like as Dr. Khullar has said, or if you are trying to include them in some research proposal or something, if you want to classify your patient. But if you are making an individual diagnosis, then it is altogether different. You don't have to fulfill, or you don't have to go by the point system that they should be fulfilled, like to make a diagnosis of SLE. So that is why initial question, like you should know that these are classification criteria and not the diagnostic criteria. Right. So yeah. So yeah, I think if you are again short of kidney biopsy, you already know that this patient is a systemic lupus erythematosus, and this patient had these kind of manifestation. What will be your diagnosis? That what are you expecting in kidney biopsy? Now you have kidney biopsy, that is altogether different thing. But before kidney biopsy report was available, what would have been your diagnosis?
So since patient is a male patient, and he's an Asian male patient with proteinuria, hematuria, and acute nephrotic presentation, I would like to keep the possibility of class 3 or 4 lupus nephritis. Or even as the patient had 4.6 gram of proteinuria, nephrotic range proteinuria, class 5 membranous lupus nephritis could also be one of the...
Class 5 alone you are expecting will explain everything?
Sir, not alone, but along with 3 and 4, it could be class 5.
So in that order, Kamakshi, what should come to your mind first? You said class 3 or class 4. Should it be class 3 or class 4, or class 4 or class 3? So it makes a difference, you see. The first thing which comes to mind because of the common occurrence should be class 4 rather than class 3. So in that order, 4, 3, and what are the percentages? Relative occurrence of which one is the commonest and which one is the next common, and then the third commonest.
Sir, around 40% of the patients with lupus nephritis, 40% will have class 5 lupus nephritis.
Class 5?
Yes, sir. Membranous type, sir.
That makes that the commonest?
40% you are saying?
40%, sir.
Okay, go ahead.
And sir, with the again, sir, with class, those with like the class 4 can present with rapidly progressive renal failure, around 25 to...
No. Again, listen to the question.
Question
Suppose
again
you
was
do
same.
100, you do biopsy of 100 SLE patients, like all have renal involvement. 100 patients you are doing biopsy. Now, out of these 100 patients, what is your expectation that how many patients will have class 4, how many will have 3, how many will have 5, how many have 2? Like depending on the epidemiology which are there. And these 100 patients includes every kind of presentation like nephrotic, RPRF, AKI, everything is included. 100 patients are there. What is your expectation?
Sir, I think I'm not sure, sir, but 40% with the membranous and around 50 to 60% with the class 3 or class 4, sir. With the, I think less than 20% with class 1 or 2, sir. But I'm not sure, sir.
You are crossing figure of 100%. So, but you have to tell which is the most common class. At least this much you can say.
Sir,
And don't
4.
combine class 3 and 4 in one go, because they are different.
Yes, sir. That's focal and that's diffuse, sir.
Yes.
The class 4 is the most
Is
common.
most common.
Hmm.
How much percentage you think?
Sir,
Class 4. Don't mix class 3.
60%, sir.
So 60% becomes class 4. What is next most common? Second most common.
Second most common would be, sir, class 5.
How much?
Sir,
So I think you should go back and read
yes,
what is has
I'm not sure,
published.
sir.
Yeah, okay, that is fine. But you should go back and read. But don't say 40% as class 5. That will be grossly wrong statement to make.
So you already
But,
got the hint, Kamakshi, because so you had the hint that class 4 is the commonest, and regardless and irrespective whether it's a male or a female. We only talk about severity, which may be different, but then very difficult to differentiate between 4 and 3 clinically unless you have the biopsy. But then the occurrence is commoner with class 4. It's more common to have class 4, 3, and then 5. And together, 3, 4, and 5 account for about 70 to 80% of all lupus.
So yeah, so again, the most common, there is no doubt it is class 4. But when it comes to second most common, you can debate. So if you read the papers, which have been published, classically it has been stated that class 3 is the second most common and class 5 comes at number 3. But if you see the changing spectrum, even in lupus nephritis, there is changing spectrum. And if you see even papers from West as well as from India, now class 5 is coming as second most common, right? The reason may be that we are better in picking up class 5 with presence of electron microscopy and good immunofluorescence. But class 5 is nowadays second most common. Even in our series, class 5 is second most common after class 4, and third is class 3, right? And even in other people's series, like from SGPGI, people were saying in a discussion that they are also finding class 5 as the second most common. So one can debate whether it is class 3 or 5,
especially,
but class 4, there is no doubt. Class 4, there is no doubt it is the most common, right?
That's why, Kamakshi, you should have taken the hint when I asked you. I was having objection when you said 3 or 4. It should have been 4 or 3. That was my objection to this thing. And of course, what Dr. Manish is saying, and since we are also including class 5 in combination with focal proliferative and diffuse proliferative, so that also increases the spectrum of class 5 combination. So yes, so that's important to know. How often you said you were basing your diagnosis on the fact that your patient had hematuria, and that's why you were inclined to believe that it is going to turn out to be class 3 or class 4 rather than class 5. How often do you think can your patient have class 4 yet no hematuria on urine? Do you think that's possible? A proliferative lesion not having hematuria, even when
Yes.
one has carefully looked for it?
Certain series, it has been documented from 0 to 60% of the patients can have
60 may be a bit too much. 0 to 30 to 40%. I mean, where even when people believed they had carefully looked for microscopic hematuria, they did not at various stages, at least initial stages of the presentation of an SLE patient. Then the biopsy turned out to be class 4. That's one.
Yes.
And how common is gross hematuria in lupus nephritis?
So gross hematuria is less than 5%. We see
So
microscopic.
it's rare to get a gross hematuria. Microscopic hematuria is most common.
Yes.
So again, if
the
you
other
have,
way around, I'm sorry to interrupt. Sorry, Sunish, since we were here, the other way around, your patient had no hematuria, and going by Dr. Rathi's question, what would you believe your patient has? No hematuria, and forget about this 0 to 40% of this thing. You will stay. You always believe that proliferative lesion will have microscopic hematuria. Let's say your patient of SLE has proteinuria but no RBCs. So what is your clinical diagnosis?
Sir, it can be class 5, sir, then membranous.
Okay, easy. Next, move on one by one. Class 5 is fine. Class 1 is fine
class
as well.
1 to
Anything
even
else? So
class
these
6.
are easy questions. Anything else which comes to your mind?
So even class 6 where there is advanced sclerosis.
Okay. Then anything else? Move away from these classes, and still patient has SLE.
Lupus podocytopathy could be one.
So that's going to present like one of these.
so
Anything else?
again, Kamakshi, let me reframe this question again. You have 100 patients of SLE who have only nephrotic range proteinuria, normal renal function, no microscopic hematuria. You do biopsy in all these 100 patients. Which will be the most common class? Pure nephrotic, no microscopic hematuria, no renal dysfunction, SLE, and you do biopsy.
So not amongst these classes.
No, in these classes only.
In these classes
which you
only.
think is the most common class?
So the class
in these
4
kind
then.
of patients. Yes.
So,
So that is what Dr. Khullar wanted to tell, like you to tell us that even in pure nephrotic range proteinuria or even subnephrotic proteinuria without microscopic hematuria, without renal dysfunction, where you are not thinking of any proliferative lesion, still in those patients, class 4 is the most common.
That's
right?
the commonest. Always remember that. And the question which I wanted you to answer was, even you should think of APLA. So something which we miss very often. If you have proteinuria yet no hematuria, you should also, in a patient with SLE, think of APLA as well. AP.
So in this patient, you have said that your clinical diagnosis will be class 4. Anything else you can think of? Because initially he presented with some mild renal dysfunction. He was given steroids, and then it improved, and then steroids were tapered, and then it worsened. Right? The renal dysfunction worsened. What is your interpretation of this?
So there was because it was class 4, sir. The crescents were cellular crescents, sir, and which responded to the immunosuppressive therapy, and the renal function improved.
So one is the crescentic transformation of the previous existing whatever cream, or because there was initial renal dysfunction, right?
Yes.
It improved with just steroids. He was just given 20-40 milligram of omnacortil. He improved, and then steroids were tapered, and then he again came back with proteinuria and renal dysfunction. So one is it has flared with crescentic transformation. Anything else?
Just Kamakshi, just intervention. The biopsy was done in May, isn't it?
Sir, in June.
In June. And the cellular crescents were encountered in June.
Yes, sir.
Isn't it? What is your feeling? He was started on treatment in February.
Sir, he was started his treatment on February, but there was it was stopped, sir. And after stopping the steroids, he again developed a flare, sir.
You
Because
feel that there was a
renal-
class 4 lesion in February,
Yes, sir.
which responded to 20 milligram of steroids. Because he received, I think, 20, you mentioned 20
40, sir.
milligram of
It
steroids.
was later increased to 40, sir.
No, that was after biopsy.
After
What we are trying to ask you, that what can be the reason that initially he had some renal dysfunction. With just 20 milligram of steroid, he improved, and then the steroids were stopped, and then he had flare, right? He again had nephrotic range proteinuria and again had renal dysfunction. So how you interpret this? One, you have said, and we agree with you, that he was to start with, say, class 3 or 4. He improved somehow with just minimum doses of steroid. Steroid was stopped, and this disease came back and with this presentic transformation. That is fine. What can be other explanations?
so
That is what Dr.
unfortunately,
Varma is also trying to ask. Like, do you expect class 4 to respond so beautifully with just 20 milligram of steroids? Or do you think it was to begin with some other class and it had a class transformation? That is what.
So it could be class switching.
Excuse me. I'd like to just add to that question. Supposing you had a serum creatinine of 2.1 at that time, no biopsy was done, would it be appropriate to treat such a patient only with steroids when you already had renal involvement, at least on clinical grounds?
No,
I
sir.
think if you clarify, just to clarify, sir, apparently at that point in time, the treating doctor had not thought of SLE, sir. So it probably the patient went with some skin lesions and some renal dysfunction. Biopsy was not contemplated, and he was symptomatically treated. Luckily, he improved with steroids, and that was it. It was only later he went to the nephrologist, and at that point in time, the everything started falling in place. Sir. So
yeah, but my question is that if Dr. Kamakshi were to see such a patient, would she feel justified in giving such a patient only steroids or only low dose steroids?
No, sir. So
yeah,
with
that
such a
is
patient,
exactly.
I would like to add, sir, with the I would like to pulse him with the IV methylprednisolone. I would like to add another immunosuppressive agent, sir.
Yeah, that is what I would consider. Even if the patient refuses a biopsy, I would presume that there is a significant renal involvement, possibly class 3 or 4, and therefore I would definitely add a second immunosuppressive agent like mycophenolate mofetil.
Yes, sir.
That's one point that I wanted to make. There's one other point. The second time when the biopsy was done,
yes, sir,
the patient had a creatinine of 2.9.
Yes, sir.
And that was on the 30th of May. And
yes,
by the 19th of June, you mentioned that the creatinine had come down to 0.8.
Yes, sir.
So is that the behavior of a class 4 lupus nephritis when given immunosuppression? Does creatinine improve so rapidly? In just 2 to 3 weeks' time, it came down to absolutely normal levels? To my mind, that is not the case.
Yeah.
Yes, sir.
Was she given steroids also here, methylpred?
Yes, sir. He was actually given pulse with the 500 milligram of methylprednisolone was given. So 3 doses.
Sir, Dr. Sakhuja, sir, I think your point is very valid, and we usually don't expect, but exceptions can always be there, but that is not the usual course. And that is why in the initial discussion, I also asked, is it nephrotic syndrome with AKI? Because AKI is the one thing which you expect a faster resolution. Say your nephrotic proteinuria is resolving. You see in biopsy, there is also ATN is there and something is there. So is it a what we are thinking is a proliferative is contributing to everything, and it is a nephritic syndrome. Is it actually nephritic syndrome? The way this patient is behaving, it doesn't look like, as Professor Sakhuja has said, usually they take time. Even in first course, like he was just given 20 milligram of steroid, and with just 20 milligram of steroid, he improved. Like he came back to normal renal function. So this is not the usual course.
Yeah, that's
Varma was also
the
saying. Yeah,
that's the important point that
Kamakshi, what is
missed out.
faster acting? Steroids or MMF or cyclophosphamide?
So cyclophosphamide is faster acting.
No. It is the steroids which are faster.
Induction. Kamakshi, induction is with the steroids. So
Steroids
Fastest-
and cyclophosphamide.
you're
fastest,
long
no.
action.
Even cyclophosphamide is not fastest. The steroid is fastest. Even
Yeah.
second fastest is not cyclophosphamide.
Yeah. Their
So
action is
cyclophosphamide-
prolonged, but they are slow to act. Fastest acting is steroids only.
Okay, sir.
So just for curiosity, Dr. Manish, which one do you believe would be the second fastest?
No. You can debate between mycophenolate, mofetil, and cyclophosphamide, because cyclophosphamide, we have a known phenomena, like cyclophosphamide takes 10 to 14 days to reach its peak action. But mycophenolate, mofetil, we don't have. So we usually start at a lower dose and it peaks into. One
In
can
that-
still not say.
Yeah, no, it was little out of context, but then I was referring to that study from China, which showed that the multi-target therapy, a combination of tacrolimus and MMF, was quicker as compared to the other standard of care as well. So in that order, but then yes, certainly steroids
But
will.
the reason for that is different. The reason is because of the action on podocyte of tacrolimus, and because of that action, the proteinuria responds faster with tacrolimus. If you give proteinuria, even in our experience, within 2 weeks, within 10 days, patient will go into kind of complete remission, but that is not taking
True.
care of disease activity. That is taking care of the podocyte.
Yeah, so that was
action
the
on the
shortcoming
podocyte.
of that trial. They did mention that we don't know, because to take care of the proliferative lesion, obviously it will take time. But then yes, the non lupus related things probably would be taken care of, because tacrolimus has other properties as well to take care. Yeah, of course.
So Kamakshi, coming back to the original question, like this high creatinine, normalizing, and then again high creatinine. So we have discussed two possibilities. One is class transformation. So maybe he was say 2 or 3 or 4, whatever, to begin with and transform to 4. Second is he was class 4, became crescentic transformation. What are other possibilities?
Sir, it could be acute kidney injury that can be secondary to some drugs that he's taking. He was started on ramipril, ACE inhibitors, ARBs, diuretics.
No, you should not consider, in fact, because this increase in creatinine occurred with stoppage of steroids. So you should think of disease-related things rather than non-disease-related things. So in disease-related things, one we have discussed is class transformation. Second point we have discussed is crescentic transformation. Other disease-related things, what can you think of?
Sir, any presence of APLA or any renal vein, renal arterial thrombosis?
So APLA, renal arterial vein thrombosis, is fine, but more common than that. May or may not be related to APLA.
What ascertains the severity of kidney injury? Is it the glomerulars or something else?
So the tubular function.
So do you think the tubulo-interstitial involvement?
The interstitial fibrosis and tubular atrophy.
Not atrophy, that wouldn't respond then. That will not revert to
the
normal.
Interstitial inflammation.
So again, yes, that is again one of the reason that he may have worsened. What other thing? Disease related?
So then the neutrophilic infiltration of the glomerulus.
नहीं वो तो proliferative का part हो गया ना. So we have talked about glomerulus, we have talked about tubular interstitium. What is other important compartment?
So the vasculatures.
Yeah. So vessel में क्या क्या हो
TMA,
सकता है disease related?
uh,
Yes, very nice.
TMA हो सकता
So
है.
TMA, patient can develop TMA superimposed on a pre-existing lupus nephritis. So that is one thing which you should think of. What other vascular manifestation can happen?
So fibrinoid necrosis can occur in
Vasculitis.
vasculitis.
Vasculitis is a rare manifestation, but in these kind of patients where patients are not being properly treated and presents with flare, again you should keep a possibility of vasculitis. What are other vascular manifestations of lupus in kidneys? Biopsy. One you have said is TMA. Second is vasculitis. What are other manifestations?
So hyalinosis, hyaline thrombi can be there.
That is part of TMA. Hyaline thrombi. Thrombi. Hyaline.
So
Anything
atherosclerotic
else?
changes.
Yes, atherosclerotic is
atherosclerotic
another
changes.
thing. What else? There are two more things. You have said 3, total 5 manifestations. So one is lupus vasculopathy, and another thing is uncomplicated vascular immune deposits. Okay. So again, you go back and read what is differences between all these things. What is uncomplicated vascular deposits? What is lupus vasculopathy? What is vasculitis? And how you differentiate in a kidney biopsy, and what are their clinical implications also?
Yes, sir.
Right. Another
So
thing.
supposing you mentioned about APLA, Kamakshi. So when will you suspect APS in these patients? How often do you encounter APLA in your patients of SLE? And are you going to believe they are going to create trouble every time they are present, or not every time?
No, sir. In about 40% of the patients we can have APLA antibodies, but they're not always can cause damage. Approximately 20% may present with the APLA syndrome.
So the frequency is much more, and in fact, the times they create the trouble is far less frequent, thankfully. So you may have them, but that doesn't mean that you need to be expecting problems arising because of those antibodies.
And sorry for shortage of time. Can we shift to the treatment protocols?
Yeah, sure, please. Dr. Manish? I think we've talked about pathology. We've talked about the manifestations. Of course, it can take the whole day to talk about.
I know.
But then, yes, you're absolutely right. The students today need to learn about the way we should treat lupus nephritis. So Kamakshi, we've talked about induction therapy in this patient, which has helped probably, but totally agree with Professor Sakhuja that this is not the way most of our patients who have class 4 show such a gratifying response with just steroids and followed it up with the MMF. So how would you treat an Indian male 46, as you said, with class 4 lupus nephritis, with this kind of picture, pathological picture?
I would just like to add to that question. This patient was given steroids and mycophenolate, isn't it?
Yes, sir.
So, would you stick with that always in this situation, or would you like to consider giving cyclophosphamide instead of mycophenolate?
So we can give the
not Kamakshi. Here, sir's question.
In this patient.
Forget about what was given to this patient. This patient has come to you. How would you treat? He's 46-year male, Indian.
Yes, sir. In class 4 lupus, sir, with the presence of crescents and or impaired renal functions, so I would like to proceed with the IV methylprednisolone pulse therapy of 500 to 750 milligram per day for 3 days. followed by oral prednisolone of 1 milligram per kg per day, and would like to for 4 to 6 weeks, and then would like to taper. And along with the since he's a
So
male,
the dose of steroid you are saying is not correct. As per
One
the
is too much.
recommendation.
One.
So if you are giving methylprednisolone pulse and that too,
Fine.
you have said 500 to 750 milligram for 3 doses. So after that, 1 mg will be higher side.
so it can be
What is the
0.8 milligram per kg per
yes,
body
that is
weight.
what is recommended.
Yes.
Then the standard dose regimen, and
And
then
not to exceed
0.8
and not to exceed
80 milligram per day, sir.
80 again is high. Yeah.
In the standard dose regimen, 80, sir.
Okay.
And then for every 2 weeks, we taper it down to from 0.8, then we taper it to 0.6 to 0.7. And then for the next 2 weeks, at the end of 1 month, we come to 30 milligram. And for every 2 weeks, we taper it another 5 milligrams.
Again, I don't know which guidelines you are putting at the end of
Standard dose
starting with 80.
regimen.
No, it's starting with 80 mg and within 1 month coming down to 30 mg. I think you are getting somewhere wrong. Again, you go back and read. This is not correct.
Because the present day stress is on smaller doses of steroids.
Yeah, see,
You are giving 500 milligram pulse, and when you are starting after 3 days, to my mind, it is 0.5, 0.6 milligram
0.6.
per kg body weight.
Yes, so that's the low dose steroid.
So that is
regimen.
not the low, that is the
0.5.
recommended KDIGO guide. Even the guidelines which are saying now 2021, the steroids
Yes.
dose is coming down. Am I right,
Yes.
Professor Rathi?
Sir, in standard dose, what they have come down to is 0.75 to 0.8 mg per kg. So initially it was 1 mg per kg, so they have brought it down to 0.75, 0.8. In low dose steroid is what you are saying is 0.5 mg per kg. But as I think somewhere last time there was a conference and we were sharing our experience when Dr. Liz Lightstone was presenting her steroid-free regimen. Then we said that we have actually done a RCT comparing 0.5 mg per kg steroid with 0.8 mg per kg steroid. So what we have noted is that our patients usually either don't respond, or if they respond, they have a early clear with 0.5 mg per kg steroid. So what we do is that even if we are giving pulses of methylprednisolone, we are keeping them at 0.75 to 0.8. But point was 1 mg is not. 1 mg is now outdated. 1 mg per kg is outdated. 80 mg is now outdated. Upper limit is 60 mg. Don't
60.
go beyond 60 mg. And your tapering schedule was also wrong. Like even if you start with 60 mg, you don't bring it down so rapidly like to 30 mg within 4 weeks. Like you should give for 4 weeks or 6 weeks, and then you rapidly taper it down. Again, you can cross-check this thing, but this is what we are doing. So in addition to steroid, what are other induction regimens and how you decide one another? Yeah, how you decide which one to give.
Yes, sir. So then the next induction agent will be cyclophosphamide. Since he's a male, of 46-year-old male, I would like to give him low dose cyclophosphamide, so which is 500 milligram every 2 weeks for 6 doses. That is for 3 months, sir, with monitoring of CBC, sir. Or I would like to give oral MMF, sir, 2 to 3 grams per day with steroids, sir, as an induction agent here.
Any other option?
Apart from cyclophosphamide, sir, we can also give, sir, other therapies like belimumab and other CD20 anti-B cell targets are there. Like CD20, we have rituximab and oleclumab.
Obinutuzumab.
Obinutuzumab. And
anything else?
So then we have.
No, don't talk about experimental or which are not yet available, which is available. Yes, any other induction? So one you have said is low dose. Other option is high dose.
High dose cyclophosphamide.
High dose. Other induction options.
So we can have
Dr. Khullar has also
And
already
sir,
mentioned.
multi-target therapy with
Yes.
low-dose tacrolimus, low-dose steroids, and mycophenolate, sir.
And what else in addition? Yeah, so one is this multi-target. Any other multi-target therapy?
So cyclophosphamide and belimumab, sir.
No, multi-target therapy. Any
What
other
about
CNI?
Voclosporin?
Sir, voclosporin. Voclosporin can be given. 23.7 milligram twice daily could be given.
So what is the advantage, Kamakshi? Why would you be so enthusiastic about voclosporin as compared to, let's say, time-old cyclosporin or tacrolimus? So what did the trial by Brad Robin have to tell you? Why are we excited about voclosporin?
So the monitoring levels, the monitoring of the drug level is not required with voclosporin.
Yes, so you don't require, and it's much more potent than cyclosporin, and you don't need the levels to be monitored.
What else? So one is you don't need to have monitored level. What is even more exciting, you may say?
Why do you believe it works better?
So then,
no, my question was why you are more excited with voclosporin. One is level you don't have to monitor.
Yes.
What else? What was there in the trial? Very exciting part
it
of
was
the trial.
more efficacious. It was
No,
found to
that
be
is
more
fine. Okay, that is fine. But even otherwise, what was more? We have just talked about steroids.
So the low dose of requirement of low dose steroids could be there. Sir.
Yeah, very, very low dose and very aggressively rapid tapering at the end of 4 weeks of treatment. At the end of 4 weeks, how much was the dose?
So it was
They
less than
tapered up.
less than 5 milligram.
Yeah, 5 milligram for 5 or 2.5 milligram. So very aggressive tapering of steroids. So that is very exciting.
So apart from voclosporin, you did mention about belimumab as well. So would you want to include, and how would you give belimumab? Is
So
it a monotherapy? Will it be monotherapy or
no, sir? It won't be monotherapy. After giving induction with steroids and belimumab along with the mycophenolate will be added, sir.
For students, I will like to ask the examiners, like in this patient where there's a crescentic lesion, what form of regimen you will prefer? Will it be cyclophosphamide based or MMF based induction?
So, General Varma, that's a very important question, and I think this is probably what Professor Sakhuja also was referring to in his question.
Yes.
When we have crescents and when we have azotemia in mind, the gut feeling always has been that one would want to use cyclophosphamide, and even rather than the ELNT regime, one would want to use the NIH regime. That's because people felt that initially that by giving us higher dose of cyclophosphamide for longer, for 6 months, probably is going to be more beneficial to the patient. But I think over a period of time, and I certainly want the other experts' opinion here as well, it's been found that they are equally efficacious. The low dose cyclophosphamide regime was found to be less toxic and probably equally efficacious. That's one. And on the other hand, even if you had the confidence to give your patient the benefit of MMF, that also was found to be equally efficacious. And I think that's, of course, debatable. There are a lot of this thing, and that's why I was referring to. As an add-on therapy, people are wanting to use, and you see, it's not available to us at the moment, but belimumab, both IV and people have even tried subcutaneous now, but then the standard would be the IV 400 milligrams on a weekly basis initially.
So the time is short. What is Professor Rathi's take?
This is the most important aspect, and I would draw Dr. Rathi's comments here as well. What would be his, so So the moment we come across crescents, the first thing which comes to mind is cyclophosphamide. And I am trying to say that that should not be the case. Dr. Rathi, your opinion?
No, I would agree with you, certainly. I think I would say two things in this. One is what tilted balance towards mycophenolate mofetil in this case was viral esophagitis. I think we are ignoring that aspect because before starting therapy itself, this patient has esophagitis and the biopsy was done and that biopsy was viral esophagitis. I presume it was a CMV or some other infection because CMV is the most common organism which causes viral esophagitis.
It was herpes. It was herpes.
Herpes.
Yeah.
It was, even if it was herpes, I
Yeah.
think this is
So it's a
what
herpes.
tilted the balance towards mycophenolate mofetil. But suppose we ignore that aspect and we take this patient as such minus viral esophagitis, then I think the debate is certainly between mycophenolate mofetil and low dose IV cyclophosphamide. Low dose IV cyclophosphamide I would prefer, but I would also like to say that there is now enough evidence that mycophenolate mofetil is equally efficacious not only in lupus nephritis with crescents but also in crescentic lupus nephritis. You know, there is also reports which are available, even Indian reports are available where people have treated even crescentic. I am not talking about rapidly progressive renal failure or dialysis requiring renal failure. I am not talking about that. I am saying with some renal dysfunction and biopsies showing you crescentic lupus nephritis, even in those we have a published evidence, even from India, that mycophenolate mofetil works. But if you want a peace of mind, you discuss with patient. If patient is also ready, my peace of mind will be in low dose cyclophosphamide rather than mycophenolate mofetil. I think, but
So
again, you have to
the
balance.
message to the student goes that induction therapy, possibly irrespective of whatever the lesion is, both low-dose cyclophosphamide and MMF will be possibly equally effective. You can weigh the pros and cons and underlying other conditions. You can give either of them. That is the opinion of both the experts.
So one another question, another misconception, not myth, which is there in everyone's mind, Kamakshi, and my question relates to that. General Varma, I have your permission. I mean, can we have the 2 minutes? Yeah. So Kamakshi is generally believed that you should wait. Supposing this patient that does not respond to your treatment and unfortunately has a progressive course and finally faces a situation of advanced CKD, and you are planning a transplantation, all right? When is what, in your opinion, should be the timing for transplantation of these patients? I'll tell you, this is what we generally believed, that you should wait. You should wait for the disease activity to get minimized, maybe allow your patients to remain on dialysis for 1 or 2 years, and probably the uremia takes care of the autoimmunity and your patient loses even ANA positivity. And then finally you go ahead with transplantation. Is that what you believe even in 2022, or you have a difference of opinion? Now, what I mean is your patient from a creatinine of 0.8 goes to 1.5 to 3 to 4 now. Now, what is your plan?
I think these questions we will.
No, Kamakshi, you got my question.
Yes,
Which means, would you want to put your patient on dialysis and then do a transplant, or will you go in for a preemptive transplant?
So, so we can go for a preemptive transplant, sir.
But mind you, your patient has a lot of disease activity. I mean, at 4 also the DSDN
after evaluation of sir anti-DS, we need to check sir anti-DS DNA titers, the complement levels.
Is there. The disease is active. The disease is still active. DSDN is positive, complement is low, ESR is high. The creatinine is mounting. The patient has a willing donor. His younger brother is willing to donate. Okay, let me rephrase. His elder brother, who is 65, is willing to donate.
I think
so we can go like if the burnt out So we go for the burnt out disease where there is.
Yeah. So that was the question. And that was the reason I was asking this question. Traditionally, we all believe that we should allow the disease to burn out and then do the transplant. But there is enough data which says that preemptive transplantation, even in lupus nephritis, the results were far superior than allowing the patient to remain on dialysis. That is why I was asking this question and referring to this as a myth. But I certainly want Professor Sakhuja's and Professor Khair's opinion here as well. Professor Khair, we have not been listening to you. Please, sir, don't deprive us of your...
Professor Khair, your comment about timing of transplant, if he's around. Professor Sakhuja.
Yes.
Yes, I would by and large agree with what Dinesh just said, that generally one prefers that the disease is burnt out before you go for a transplant. And generally those patients of lupus nephritis who have gone on to dialysis, the disease activity burns out. So once a patient is on maintenance dialysis, then it's very unusual for there to be lupus disease activity going on. So the disease usually burns out soon after that. And then you can consider doing a transplant in this patient.
Yeah. Now,
so, sorry, Dr. Varma, please.
One or two questions from her before we go.
Yeah,
the
please.
Difference between lupus manifestation in male and female and adult and child. If Kamakshi can answer that.
Yes.
He's a male lupus. Any difference in male lupus and female lupus?
Yes, sir. Male lupus will have
rapid fire.
Male lupus will have a poorer prognosis, sir, of the disease, and will have more of proliferative lesions, sir. In females, then pregnancy will lead to flare of the SLE.
I think Professor Khullar can.
I think so. The other question was the child lupus and the adult lupus. You can try that first, Kamakshi.
So the child lupus, earlier age of onset is associated with poorer outcomes, poor prognosis as compared to the adult onset. And so the lupus nephritis is the renal manifestations are more common in the child, more common in the childhood pediatric lupus.
I think you will have to read that also. Yeah.
Kamakshi, any genes which can protect your lupus nephritis patient? Any HLA protection?
So HLA DRB1.
No. 4 and DR4 and 15 are protective. 4 and 15 are protective, and I believe 11 is not. 11 is what predisposes. So if your patient has HLA DR4 or DR15, it's a good news for your patient.
And what is neonatal lupus?
So neonatal lupus is when there is transplacental passage of the lupus antibodies from the mother to the
which antibodies
child,
manifestations?
So anti-Smith, anti-Rho and anti-La antibodies, which can cause conduction. So conduction defects in the baby.
And
AV blocks.
Rash, thrombocytopenia.
Rash and thrombocytopenia.
Okay. At what stage you will like to add, Professor Khullar was asking, the newer beluzumab, at what stage you will like to add that? Because initial induction you are trying to give with cyclophosphamide or MMF. Yes. Now, the two agents what have been mentioned is voclosporin, and the Professor Rathi mentioned that one is you can reduce the dose of steroids significantly. Second, you don't need to monitor the levels. That is the advantage of voclosporin. To which patient you will like to give voclosporin or beluzumab? And after that, I hand over to Professor Sakhuja.
Certain patients who have they do not have any complete or partial remission even after 6 to 12 months of therapy. or once they have achieved partial or complete remission and then they are relapsing? Answer, refractory lupus where even after 12 months of intensive therapy, they are not responding, sir.
Professor Sakhuja, please.
I think we've reasonably covered most of the subject, and now it's already past 8 o'clock. So unless there are any one or two last minute comments from any of the examiners or moderators,
No,
I think we can.
I think, sir, lupus is such a subject that it is difficult to cover in 1.5 hours.
I
We can
fully
keep on
Yeah,
discussing.
that's true.
Yeah,
That is
especially with
that is
me
always
and
true.
Dr. Khullar at helm of affair, like we can keep on discussing for hours and hours. But I think one important field which we have missed is pregnancy and lupus. But we will keep it for some other time. We are already exceeded time, but that is another important area, pregnancy and lupus. But it's
I
okay.
just want to add one more comment, General Varma, that this is for the students, that is, we have come a long way as far as the management of lupus nephritis is concerned. A dreaded disease in the last century doesn't appear to be that dreaded, and we have conquered about 70 to 80% of the patient population of lupus nephritis. Yet there is an unmet need, and that is to the tune of 20 to 30%, and yet you still get about 10% of these patients landing up in end-stage kidney disease. So we need to look for better strategies. Belimumab and voclosporin are a step in the right direction, but we are, and as Dr. Rathi also is a part of many clinical trials, we are targeting the various pathogenetic mechanisms. We are targeting IL-17 with a drug called secukinumab. We are targeting IL-6 with etolizumab. We are targeting interferon with anifrolumab. And of course, we know obinutuzumab, the humanized variety of CD20 is having a role. We didn't talk about rituximab. It has a definitive role to play, but then as the paucity of time didn't allow us to talk about where to use rituximab and where not to at the same time. So a lot of discussion, but then yes, what I wanted to make the point was, it's a very exciting field ahead with as far as the management of lupus nephritis is concerned. We are looking at therapies which target complement. We are looking at even so many other aspects, the April pathway, the whole lot of this thing. So it's very exciting to read about the pathogenesis of lupus nephritis, which will give us an idea as to what the various the research teams are looking at by way of new molecules. Yeah.
I think the students will agree that there have been two masters, Professor Khullar and Professor Rathi. Both of them have got tremendous original work, a lot of publications. Professor Rathi's publication, international publications are there on the management of lupus. But I also agree that time allotted is not enough to cover a huge topic of lupus. I think these masters can carry on only with the pathology or biopsy for 2 hours. You give them any area they can tear upon on the lupus field. I think in true spirit, if Professor Sakhuja agrees, I think we will have to have one more session on management issues only, because the topic is covered, but not to the full extent. I thank both the speakers profusely for their masterly teaching of the students in their masterly way. And I hand over to Professor Sakhuja for the final comment and closure.
Thank you very much, General Varma. Yes, I think it's been a very good session with a lot of important learning points brought out by both Dr. Dinesh and Dr. Rathi. So I'd like to convey my thanks once again to all of you, and also to Mr. Raja of Microlabs Limited. And that's it from my end. Thank you very much indeed.
Thank you very much. There were more than 131 students who are glued up to now.
And nice job, Kamakshi. I'm sure Dr. Manish also will compliment you. You definitely need to hone up few skills, but then I think you were good
No,
enough.
very well done.
She is,
Very well done.
she is your student, so that is expected out of her.
Thank you, sir.
Thank you very much.
Thank you, sir.
Thank you.
Thank you, everyone. Thank you. Good night.
Thank you, sir.
Bye.